The purpose of really this talk is to kind of give, as the title suggests, an overview of what happened, with the U.S. healthcare system historically, and why did the Affordable Care Act come to be, what is it about? Why did they do the things that they're doing? This all kind of came about because I took a class about this, and when I was getting my MPH. And I really learned a lot of things that I didn't know myself, and I thought, this is an important thing for, residents and medical students, but also really all of us should know these numbers, should know why this is happening. And what I really try to do with this talk is make it as objective as possible, as fact-driven as possible, and really just present what has happened historically and why the provisions were made. And which is challenging with this topic because it's very inflammatory. There's a lot of politicalization of things, but I hope you'll find that this is as objective and apolitical as possible. So this is a very extensive topic, obviously, but we'll try to cover it in a brief amount of time. So why are we talking about this? So the most important what you want to see here is this is the U.S. healthcare spending as a percentage of our GDP. And obviously, as we go over time, in 2010, it was just around 18%, and these were the projected numbers without the Affordable Care Act in place. And this is what we have compared to all the what they call the OECD countries, or all of the other kind of developed countries. And as you can see, the average is about 10%, and we're way up here at 18%. So we're by far spending way more than anybody else in terms of our GDP on healthcare. But that's not necessarily leading to good value for our dollars. So what we have is a lot of healthcare disparities, which we see a lot of here in Louisiana. If you look at the life expectancy, compared to these other countries, we're in the lower end. And we also have a growth in the number of uninsured over time. So what we basically see is that this problem is going to get worse. And something needed to be done about it, and this is what the attempt was. So this is why we're talking about this topic. Also, feel free, please raise your hand if you have any questions, if you want a clarification on anything. There is a lot that we're going to cover in this short amount of time. So this is kind of an outline of what we're going to talk about. We're going to go over why healthcare spending is rising. We're going to define what insurance is, go over private and public financing, and then talk about the Affordable Care Act. What are the main provisions of it? Obviously, it's a 2,000-page document, so we're not going to cover most of it, but we'll kind of highlight the key points and then talk about the Supreme Court rulings that have happened since. So why is healthcare spending rising? So here we have a breakdown of healthcare spending in 1975 and in 2010 in terms of percentages of what it's spent on. So in 1975, it was 8% of our GDP, and now it's, again, close to that 18% in 2010. So similar to what we saw in those graphs earlier. So what you can see is the two major areas of growth, things that are taking up more of the pie than they used to, are drugs, so it went from 7% to 11%, administrative costs, and other, which is really medical devices. So we'll kind of cover this a little bit later. These two, we have heard a lot about new drugs, new devices, how much they cost, and so there are some things within the Affordable Care Act that are there to address that, and we'll cover those as well. But, one of the main issues is that healthcare spending is concentrated among very few people. So if you take the top 1% of healthcare spenders, they account for 23% of all healthcare dollars that we're spending. And as you go down, you can see this number, rises up pretty significantly. The top 20% of spenders is over 80% of all money we're spending on just 20% of the people. And then if you look at the top half, that's 97%. So, these numbers are pretty striking. And this is really if we want to target where we're going to try to save some money, it's going to be in this area here. So when they went out and asked, thousands of people and said, what do you think is the cost, the reason why cost is rising? And this is not doctors, these are not healthcare providers, these are just lay people. And most of them felt that it was money that were high profits by drug and insurance companies. Malpractice was on there, which is good to see, I think. There was a lot of what people perceive as greed and waste that occurs in the healthcare system. Aging of the population. Only half of the people felt that this was a reason. Use of expensive drugs, again, less than half. Doctors making too much money. So only a third of the people thought that. And only 5% put it as their number one thing that they thought would be a reason for high healthcare costs. So at least we're not perceived as making too much money by the lay people. And but what are the real reasons? So one of the main things is that slide that I showed you before, where the top 1% are accounting for so much of our healthcare expenditure, and this is really due to aging of the population. So again, this is a similar statistic, but about 30% of Medicare spending is concentrated among the top 5% or the 5% in Medicare who die each year, and then 10% of all U.S. healthcare spending is concentrated among the 1% who die each year. So, the challenge is finding out who's going to die that year, and that's always a tricky situation. Another issue is health coverage over time. As time has gone on, we've actually seen how much an individual has to spend on their own health care go down over time. So the cost of premiums have gone down up until the Affordable Care Act. And that is problematic for several reasons, and we'll kind of drill down on that a little bit more, because that's a big reason that the health insurance reform has tried to address. But what we saw was the Rand Corporation did a health insurance experiment where they took thousands of people and randomized them into getting what's called a Cadillac plan or a platinum plan versus a silver plan. And I'll explain what the differences are. But in one plan, more services are covered, and they're covered for cheaper. So you have to put less money into the system to get what you're going to get. And in others, you have to pay more. And what they saw is that people in the plans that had lower cost sharing, right, so in those platinum plans, had higher spending. They used more services because they had to pay less, and that's pretty obvious. But that didn't necessarily associate with better health outcomes. So they had some marginal improvement in their blood pressure numbers, but that was pretty much it. Nothing else was any better. There was not better glucose control, not better, lower incidences of MI, better cholesterol, none of that, just blood pressure. So what they call this is low value care. And so as you see, over time, we've had to spend less as individuals, but we're, again, not, spending more on healthcare, but not necessarily getting better outcomes. There's also increased healthcare spending for chronic conditions, and they say about 10% or $80 billion is due to obesity, and these are some of the things that are out there for people to eat. Maybe not the best thing to talk about while you're eating fried chicken for lunch, but this is one of the issues. And new tech and drugs, and then administrative costs. So let's talk about what is insurance. It's not just kind of a straightforward thing, and so we'll kind of explain. We'll skip this video, but it's basically the way that insurance works is, I'll just run through a hypothetical example. This is not exactly how it works, but I think these numbers sort of tell exactly what's going on. So let's say you have a 1 in 20% chance of a $100,000 hospitalization. So what you would do, the insurance company would do, is set the premium at $5,000 with a 10% administration fee. And this is how it's done. This is what actuaries do. I mean, obviously the math is much more complicated, but essentially this is what it boils down to. So that they would set it as $5,500, and that would be what's called community rating, where everyone pays that, everyone in the community. Now, the other way to do it is what's called experience rating. So you say 3/4 of the population is healthy, and so they only have a 1 in 40 chance of being hospitalized. So their premium is $2,500, and then 1/4 of the population is sick, and so they'll have a 1 in 8 chance of being hospitalized, and so their premiums are set at $12,500. They're more likely to experience the event, so they have to pay more. But there's also a moral hazard associated with that, where you say, how do you feel about having sick people pay a lot more money for their health care? And at the same time, how do we feel about having healthy people pay to subsidize sick people in the community rating? And so these are things that they had to think about when you talk about insurance and when you talk about insurance reform. So, other things that insurers can do is they can vary the scope of the insurance sold, so they can vary the amount of cost sharing, so that's your deductible, and a variation in the breadth of services covered. For example, drugs, prescriptions, long-term care, and things like that. So what it boils down to is the actuarial value, which is the percent of total spending that's covered by the insurer. So you have a bronze, which is 60 to 69%, silver, which is 70 to 79%, gold, which is 80 to 89%, and platinum, which is 90% or higher. So these are important. These are called the rate bands, and this will become more obvious. We'll talk a little bit more about it later when we talk about the Affordable Care Act. But and again, this is one of an important thing to define, which is called adverse selection, where obviously if you're sick, you're going to have more expensive health care, and you're going to want to choose a platinum coverage where you're more likely to pay less, versus healthy people are more likely to choose bronze coverage because they don't use it as much, so they don't want to pay the higher premiums. And then the last thing they can vary is the network of providers. So one of the advantages to grouping insurance is a lower administrative cost. So as the number of people increase within the plan, so if you're buying insurance yourself versus if you work at a company with 1,000+ workers, the administrative cost for the insurer goes down significantly. It's only it's less than 10% per person for if you have 1,000+ workers. So what you're doing is you're increasing the bargaining power, you're making it easier to shop across plans, and you're pooling people together with different health statuses, and so that allows for cheaper administration, cheaper costs for the company and for the system in general. So how does the insurance look like in the US? So what we have is the majority of patients are under private insurance, which is employment-based, and then some, very few, are individually purchased. Again, these are before 2011, 2012 numbers. This is the breakdown of Medicare and Medicaid. This was before 13.4% were uninsured, and we had 3.4% which were VA covered or military. So how does private insurance work? And we'll kind of delve into that a little bit more. So employment-based coverage, so essentially what happens is your employee provides benefits, and then that's excluded from income taxes and payroll taxes, okay? So that I'll run through an example so it'll make more sense. And then the tax subsidy is the reduction in income tax paid by the individual, and then that's about 35% for premiums. So let's say you make $50,000 a year in total annual compensation, and your income tax rate is 20%. So what you'll do is you'll pay, and your premium is $5,000 a year, let's say. So if your employer doesn't offer coverage, then your income tax is going to be $10,000, which is 0.2 times $50,000, and then you'll have to spend money on top of it to buy insurance. You'll spend that $5,000. But let's say the employer pays $5,000 for coverage. So your salary will actually be less. It'll be $45,000. So the employer will get to pay you less, which is advantageous to them. And your income tax is going to be less because you're making less money, and this is this $5,000 that they take out is not taxable to you. And so you get essentially what's called a tax subsidy of $1,000. Or if you wanted to look at it, you can just multiply 0.2 times 5,000, which is your premium, and you get that $1,000. So you can get about it both different ways, but what you see here is that it's advantageous for people to take more generous coverage, get higher premiums because they get better tax subsidies. And it's more generous, it's better for people, right? So if this number is higher, this number is going to be higher. Also, if your income is higher, this number is going to be higher because you're going to be taxed more, but that also incentivizes you to get a plan that has a higher premium as well. Does that make sense? And so, again, we're incentivizing people to take higher coverage, better coverage, more expensive coverage, which then leads them to utilizing the services more and spending more money in the system. And it leads to these things, which is called vertical inequity and horizontal inequity, or moral hazard. So what vertical inequity is what I was talking about, where people who are taxed more are incentivized to get better coverage, and that versus if you are taxed less, it's actually more expensive for you to obtain better coverage. And so there's a vertical inequity in the sense that people who make more money are incentivized to get insurance versus people that don't. And there's also what's called a horizontal inequity where, again, you're incentivized to get better coverage. Some other issues that happen with employment-based coverage is there's a lack of continuity with job coverage. So if, for example, you lose your job, you don't necessarily get to keep your insurance. And then we're insulated from the true cost of premiums, both for the employer and the employee. And there's less choice when you get to smaller firms. So if you look at this sort of, again, highlights the same issue, is that, the tax expenditure by family income, so this is how much we're getting, you're getting back in taxes as you go up in income, you're getting back a lot more just from federal health benefits. So again, this is part of that vertical inequity. So one of the other issues too is those people who are in the individual market who don't get insurance through their employer, and prior to the ACA, this was a problem. So what you can see here is for people who are in the small group market, so people who worked in a firm that was 2 to 50 people, and it's even better for people who work in firms that are larger than that. But essentially what you can see is most of these people are getting platinum, gold, and silver insurance, with very few people buying, getting bronze or what's considered tin, which is less than 60%. Not a lot of them had guaranteed issue and community rating in terms of states, but all of them had what's called these rate bands, which is, again, this is what I was talking about, that bronze, silver, gold, and platinum, which allows people to understand what they're getting. And the majority of states ban the use of using the health status using pre-existing conditions to stop people from getting insurance. Versus in the individual market, less guaranteed issue and community rating, very few states, again, having rate bans. So again, people don't know what they're buying. They're just buying what they consider cheap. And the majority of states allowing the full use of health status and higher administrative costs, like we talked about. And so what that makes it, for people with pre-existing condition that are in the individual market, it makes them very hard to get insurance and very hard to understand what they're getting. And this is what you get. You get the majority of people in the individual market buying tin and bronze insurance because it's expensive and oftentimes they can't get it. So then we're going to go into Medicare and Medicaid next. So what is Medicare? So Medicare, most of you know, was established in 1965, and it's really the public health care insurance program. It's primarily for the elderly, right? So in 2013, it covered more than 40 million people over the age of 65. And it also covered 8.7 million under the age of 65 who were disabled. So you have to have 2 years of SSDI, Social Security Disability Insurance, or end-stage renal disease or ALS. Any of those patients are automatically covered under Medicare. The nice thing about Medicare is because all of these people are pooled together, there's a very low amount of administrative costs, only 3% on average versus 14% on average for private. And this is what Medicare breakdown are essentially broken down to. So the majority of it is going to hospital inpatient services. Physician payments account for about 19%. 17% is this other services, so things like SNFs or home health, et cetera. Medicare Advantage, which I'll explain a little bit later, and then outpatient drugs. So I'm sure you see this on people's insurance: Medicare Part A, Part B, Part C, and Part D. I didn't know what these were, and so I think it's important to kind of cover it a little bit. So what is Part A? Part A is, again, this inpatient hospital system and skilled nursing facility. So this is what is covered under Part A. And everyone gets Part A. So it's financed by a combined payroll tax of 2.9% on current wages. When it started, it was only about 0.35% in 1965. So 1.45% is on employees, and then the same is on employers. And then in 2013, under the ACA, people who make over $200,000 or couples who make over $250,000 had added taxes, which was about 0.9% on employee wages, and then a new 2.35% tax on unearned income like capital gains. And so the difference between the revenue that they get in and how much they're spending is taken from a hospital insurance trust fund, which is what you see here. And this is the projections of when it was going to run out. So currently the projection is it'll run out by 2026. So Part B is what we physicians get paid out in outpatient care. So it's also financed by tax revenue and premiums. So on average it's about $105 a month in 2014, which is pretty good. Since 2007, people who make above $85,000 or $170,000, there's a couple, the premiums go up, also depending on where they live and how much they make. Part D was added in 2006, and that's for prescription drugs. It's also financed by tax revenues as well as beneficiary premiums and then state payments as well. And so in 2011, Part D premiums were higher for beneficiaries who make more money, so which range from about $49 a month to $108 a month, and this is the average now. And then the way that it works is essentially there's a deductible up to $300, and then after that, up to $2,850, the plan will pay about 75% of the cost. The patient has to pay about 25%. Up to almost $7,000, the enrollee will actually pay about half for brand name drugs and about 70% for generic drugs. And then this is what's called the donut hole, essentially. This is where, when they're between about $3,000 and $7,000, your patients are having to pay quite a bit of money for their drugs. And then after that, they get what's called catastrophic coverage, and that's when it kicks in, and the enrollee only pays 5% after that. So Part C is basically the additional coverage or supplemental coverage on top of Medicare Part A and B. And the reason that existed is, there's a lot of services that seniors need that are not covered under Medicaid. And so there's a lot of high out-of-pocket payments, and this basically prevents them from having to pay that. So for example, if you had just Part A, it would cost $1,216 per stay, or $304 per day if you go up to the patient, right? Part B, there's a high amount of deductible with 20% coinsurance, and there's a lack of catastrophic coverage for many services, so not include, for things like skilled nursing facilities, right? So not, if you don't have Part D, also drugs would not be covered underneath that. And so this is the point of having Part C insurance. And these are the things that are not covered by Medicare that, again, Part C helps to pay for. So vision, dental, hearing aids, right? And within Medicare, so the majority of people actually have employee-sponsored additional coverage. Some people have what's called Part C, which is the Medicare Advantage. Medigap is another one, and then Medicaid is for people that qualify for both. So for those people who are disabled, elderly, and poor. And then these, about 12% have no supplemental coverage. So what are the long-term issues with Medicare? So one of the biggest thing is, as we go over time, we're going to have, in 2030, we'll have 80 million people enrolled in Medicare, and we'll have less people who are working and contributing to that Medicare fund. So per beneficiary in 2030, we'll only have 2.3 people, versus right about now, we're somewhere around 3 people working per person that's in Medicare. And so this is, not financially sustainable over time. And also there's increased spending per beneficiary. So currently, Medicare makes up about 16% of our federal spending, with our total GDP or spending being about $3.5 trillion and Medicare costing $500 billion. So in terms of Medicaid, how does Medicaid work? So Medicaid is, again, for low-income people, and it essentially is administered by the states, which we'll talk about in a second. So there are 3 mandatory low-income groups that have to get Medicaid, and then the rest is up to the state discretion. So the 3 mandatory groups are low-income families, so that in 2014, the federal poverty line is about $11,600 for single, and then for a family of 4, it's $24,000. So children who are 0 to 5 that live in a family below 133% of the federal poverty level must be covered. Children 6 to 17 is at 100%. Pregnant women below 133% of the federal poverty level must be covered. And then parents of children who make below 42% of the federal poverty level have to be covered. So somebody who makes $12,000 a year or $11,000 a year and have a child can be covered, mandated under Medicaid. The elderly who receive SSI, this is what we talked about earlier, they get Medicare and Medicaid. They're what's called dual eligible. Now this is the most expensive population in the US, and you can sort of guess why. I mean, it's because they're poor and old, and so again, they have a lot of healthcare issues. If they're blind or disabled and they're receiving SSI, then they can be primary, or if they're over the age of 65, they can be dual eligible, or if they have, again, end-stage renal disease or ALS. Over time, the percentage of the population that's covered by Medicaid has risen pretty drastically, and that's due to a lot of the changes that have been made, and that's rising even more, as I'll show you a little bit later.
Vikas, is that national or Louisiana?
This is national.
Because I think, because of Bikini and John Venturi, that is, pediatricians are here, they can correct me, I thought it was 200% poverty for children. They have a much better deal in Louisiana than adults do.
Right, and so that, it's state dependent, which is what we're getting to next. But so those are the hard and fixed rules set by the federal government as to who has to get Medicaid. Okay. Now state governments get to administer the eligibility level, so they can change it based on what they want. So they have the option to increase income eligibility above the mandatory levels. For example, in Louisiana, it's 200% of the federal poverty level for children. Now, and then a very few number of states have actually historically requested waivers to cover childless adults. So here you see the median Medicaid eligibility thresholds across the nation, and this is, so for children median-wise, this is across the, so all of the states, it's about 235% of the federal poverty level you can qualify for CHIP or Medicaid. For pregnant women, it's 185%. For working parents, again, 61%. Jobless parents, 37%. And then childless adults, pretty much 0%. So if you don't have kids and you don't have a job, pretty much out of luck. So, and the state governments also administer the healthcare services provided, but they also get to decide somewhat what gets administered. So if it's mandatory that Medicaid covers physicians, hospital, and nursing facilities, but it's optional if it covers prescription drugs, dental, and rehab. And so they also, in 2005, were given more discretion on what they could cover and what the cost sharing was for that. And so they could charge people more or cover less based on whatever the states decided. So the way that Medicaid financing works is it's both financed by the state and federal governments. So what the states get is what's called FMAP, or Federal Medical Assistance funds, essentially. And so on average, each state gets about 56% of what it's spending from the federal government. And it varies between how much that state takes in and also what services they cover. So if the state expands its coverage, they'll get more money from the federal government. So if they're covering people above 200% of the federal poverty line, for example, they'll get more money from the federal government, but they'll also have to spend more themselves. But it does provide an incentive for states to expand these things. And so about 40% of what gets spent is mandatory services for mandatory groups. And then here you can see the breakdown of what, optional services for mandatory groups, mandatory services to optional groups, and then optional services for the optional groups. Here's kind of a breakdown of who's in Medicare and how much they get. So, the elderly within Medicare, this is those dual eligible people that I was talking about. So they account for about 10% of Medicaid population, but they account for about 22% of Medicaid spending. Disabled, also a huge percentage of the Medicaid spending. Adults, very little, and children also much less proportionally. So with all of that in mind, we'll kind of go over what did the 2010 Affordable Care Act try to address in each of these situations and what's happened since. We won't really talk about what's good, what's bad. We'll just kind of show numbers and kind of go into that. So there's really three primary goals of the Affordable Care Act, and this is broken down to cover the uninsured by subsidizing coverage, right? Increase regulation of private health insurers, and reduce overall spending. So one thing to note is insurance coverage, and this is prior to the ACA, so insurance coverage and employment. So traditionally we think about uninsured people and we think about people that don't have jobs, but in reality it really depends on what kind of job you have. So about 76% of the uninsured people are in working families, so people that actually have jobs. And 61% are those in full-time working families. And so, people that are self-employed or work in a small firm, they don't often get coverage. And so this was an interesting thing that I thought. The other thing is it's more concentrated under people who are 200% or less of the federal poverty line. So again, 29% of people who are 100 to 200%, and under 100%, 32% of people who live with that amount of income are uninsured. And again, this is what we talked about, with the employment coverage, it depends on what kind of job you have, whether or not you get offered that health insurance as part of your job, and that's because of administrative costs, that's because of tax incentives, And so as you get down, you see people that are in smaller firms, a large percentage of them are uninsured. And these are some of the disparities that the Affordable Care Act sought to address. So these were the main provisions that were set forth that were supposed to be done by 2014. And we'll again go through these and see which ones have been done and which ones haven't. So Medicaid expansion was supposed to, as originally written, was supposed to be for all non-elderly people under 133% of the federal poverty line. And what was going to happen is up to 2020, the states were going to get 100% of that reimbursed from the federal government. So to expand that coverage to 133% for all people, not just children, not just people with jobs, but essentially all of, even if you were childless, you were supposed to be covered under Medicaid with federal funding to the states up till 2020. And then after 2020, it was going to be 90% covered by the federal government. The second main provision was to set up these state health insurance exchanges. So that's to allow for tax credits for individuals between 100% and 400% of the federal poverty line. So people that kind of fall, who don't qualify for Medicaid, and who make 400% of the federal poverty line or less, they get tax credits. And then it also allows for private insurance options for individuals and small businesses, allows pooling of those people, and again creates different things that make it easier for private people to obtain coverage, and I'll talk about that also. It prohibited the use of pre-existing conditions by private insurers, and which is essentially guaranteed issue, and then we'll explain what adjusted community rating is. But if you remember what community rating is, it's based on everyone getting kind of charged around the same amount, not changing it based on how sick the person is. And then there's also the individual mandate, which basically means you have to have coverage or you get fined. And employers have to provide coverage, play or pay mandate, which we'll go through a little bit. So let's talk about the individual mandate and adjusted rating first. So the intent of the individual mandate, essentially saying that you have to get insurance, is to mitigate adverse selection. So if we have more people in the pool, we have more healthy people in the pool, and we're not just getting the sick people covered who are going to spend the money, but also some healthy people to offset some of those costs. And this is because we're going to have guaranteed issue and modified community rating. So in 2014, the penalty of not having insurance is about $100 per person for up to 3 family members, or 1% of the family income. In 2016 and after, it's a maximum of either $700 per person up to 3 family members, and that's adjusted by the income, or 2.5% of the family income. And then there's a lot of exemptions. For example, if you don't make enough money, if you have a religious exemption, if you're Native American, they're not required or fined. There's also adjusted community rating for premiums. So again, no variation with pre-existing health conditions, right? No variation with gender. They can charge more as you get older, but that's limited to 3 to 1 for the premiums, and then which is relative to about 5 to 1 for underlying spending, essentially. So, it is cut off. There is some variation with tobacco use, so they can charge people up to 50% more if they do smoke. And there is variation within state-defined geographic rating areas. So if you live in an area that generally is more affluent, you can actually be charged a little bit more than people, or where healthcare actually costs more money, you can be charged a little bit more. So in terms of the tax credits, how that works, it's basically a sliding scale. And what it essentially boils down to is it's based on the difference between the second cheapest silver plan and an affordable premium equal to a certain percentage of somebody's income. So, and that will vary from between 2% at 100% federal poverty line to 9.5% at 400% federal poverty line. So, again, these are the numbers for what they were in 2014, and essentially it's a taxed credit, a fixed tax credit that can then be used towards buying whatever plan you choose, but it's, and I'll sort of go through some of the numbers so it'll make more sense. Who's eligible for the tax credit? Any U.S. citizen or legal resident that lives between 100 and 400% of the federal poverty line, and they're not offered coverage by an employer. Specifically, they're not offered a silver plan or above, and it's so and they don't qualify for this 9.5%. So here's how it would work. So let's say you had somebody who was at 200% the federal poverty level, so they make about $22,000 a year. So they would get this, it would be 6.3% of how much they would be responsible for. So that's about $1,365 out-of-pocket premium contribution. So let's say that the premium for the second cheapest silver plan, which is what they want to buy, equals $5,000. So then the person would get a tax credit of $5,000 minus how much they put in, which is $1,365. They would get this amount as a tax credit. So that the net premium essentially that they would pay is this, right? Now, if they wanted to buy a gold plan instead, they have to pay more. So let's say the gold plan is $6,000. They're going to pay $1,000 more. They'll still get the same amount of tax credit, but they just have to put in more money. And essentially, the point of that was to address a lot of that inequity, that they saw, in the sense that people will have to pay more if they want to get better coverage, and then that puts more money into the system. But they also have the option to get a bronze coverage if they want and save more money that way. So how does it work for the employers? The employers with less than 50 full-time workers had no penalties at all if not offering coverage. But in 2015, employers with more than 100 full-time workers, and then in 2016, in those with more than 50, will be required to offer full-time workers, those that essentially work over 30 hours a week, affordable coverage. And what that is the employee's share is less than 9.5% of their income. And if they're not offering coverage, the employer has to pay a $2,000 penalty per full-time worker, excluding the first 30 workers. And then if they offer coverage that's not affordable as per the ACA parameters, then the employer must pay a $3,000 penalty for each full-time worker with an exchange subsidy. So by 2019, without the ACA in effect, this is the projection of coverage. The employer coverage would again still be the vast majority. Medicare and Medicaid. Medicare is going to expand, and Medicaid would shrink a little bit. Uninsured would stay around that 16%. But with the ACA, you see that Medicaid is obviously where you're going to see the greatest expansion, and then a large amount of people getting coverage through the exchanges, and uninsured going down. And this is projected for 2019. Yeah, go ahead.
Provision that was put in, didn't that make a lot of employers cut the hours of the employees so they wouldn't have to fall in that realm? Like, they made more people part-time, then hired more people and made them all part-time, and cut a lot of hours out.
Yeah, so that's definitely one of the concerns. I don't know the actual, what it has resulted in so far, but.
Like, was that people were losing hours because of that provision?
I actually think that what the opponents were suggesting is going to happen, but I don't believe there's any evidence to say it didn't happen.
So for those who didn't hear, the question was, has that resulted in employers cutting hours for people so that they don't qualify under this, basically they don't meet these parameters for 30 hours per week? And I didn't hear what. What was your answer?
The comment I made was that was the threat that
Right.
was being voiced by opponents of the Affordable Care Act, but I'm not aware of any evidence that has suggested that that has come true.
Right. Dr. Marion said he's not aware of any evidence that has actually come true. Yes?
That happened to me.
That happened to you?
I used to be a substitute teacher, and they limited us from 5 days to 3 days a week after Affordable Care Act.
So, and then this is essentially what's projected as to happen with the Affordable Care Act. So this is supposed to be the total effect on the deficit. And essentially what it's trying to show is that, initially there's going to be a drop in the deficit, and then over time, it'll probably even out, maybe go up a little bit, and then go down. And this is just, again, what they are projecting, not what I'm projecting. So what it is that over time there's going to be an increase in cost in terms of provisions, but that there should be a decrease in spending, and a decrease, which should be offset by a decrease in spending and an increase in revenue through these things, essentially. And so what they say is that the total cost will be about almost $1 trillion over 10 years, from 2010 to 2019. And the way they project that this will come in, which is the revenue, is through the Medicare payroll tax, which we talked about earlier. So that'll be about $200 billion that they expect to get. And again, that's an increase in all income for those who make over $200,000 or $250,000. They also expect a reduction in fee-for-service Medicare payments, as well as a reduction in Medicare Advantage payments. They are charging new fees for drugs, devices, and to insurers. About $100 billion in income is supposed to come from that. And there will be a tax on high premium plans, so that's what's called the Cadillac tax, in 2018, and that's supposed to generate $32 billion, and that's a 40% tax on the amount of coverage for a single person that's $10,200, or a family's that's $27,000 for the premium. Does that make sense? So they're taxing for people who have very high, very good coverage. Those people will be taxed more. So again, what that's supposed to do is disincentivize people to get those Cadillac plans, those high premium plans. And it's also supposed to set up health insurance exchange. One of the other ways to reduce healthcare spending is to set up these state health insurance exchanges. And so the way that works is it's supposed to foster transparency, so that the insurance company will be able to tell you why are they charging, by using those rate bands, you'll know exactly what you're getting, what you fall into. It's supposed to increase co-op plans and multi-state plans, and so again, by pooling together, decreasing those administrative costs and allowing for better negotiation with the insurance company, and setting a requirement for insurers to lose a certain, so they can't just charge premiums based on how much money, just to make more money. Per individual, they'll have a minimum medical loss ratio of about 80%, and then for small group markets or for large group markets, it'll be 85%. So efforts to decrease Medicare and Medicaid prices, so there'll be a reduction in the annual updates for hospitals, home health agencies, SNFs, and hospices. Pharmaceutical drug manufacturers will be required to have a 50% discount for those in the donut hole of the Medicare coverage. So those people who are between that $2,000 and $7,000, they'll have to give discounts to those people so they don't have to spend quite as much. And then there will be drug discount increases for Medicaid patients from 15% to 23%. There's also efforts to decrease Medicare utilization, and there's a ton of stuff about this. It's actually very interesting. Some of the things they're trying out now. So these are some of the things that they're trying. So one is to reduce payments to hospitals with high readmission rates, and that's adjusted for the severity of patients that they see. And then another thing is trying bundled payments over a long episode of care. So for example, if a patient, for me, comes in with laryngeal cancer, the hospital, myself, and anybody who's seeing that patient just gets one lump sum. So they give us $100,000, and based on however much money we spend to take care of that patient, we either go over that or we keep X amount based on how efficient or cost efficient our spending is. Another way is to create what's called accountable care organizations. And lastly, they've created an independent payment advisory board to examine all of these alternative payment plans to see how it works. So what is an accountable care organization? And it's basically a collection of primary care physicians, specialists, and hospitals all connected through EMR. So, I guess all of LSU would be considered an accountable care organization if we weren't all under some umbrella already. And it has to have at least 5,000 beneficiaries allocated to the ACO. And again, that's meant to try to consolidate care within these larger conglomerates. So how would the accountable care organization be paid? And this is, so one way is they receive a reward or penalty based on whether actual fee-for-service spending was lower or higher than a benchmark amount that's established by Medicare. And it's a prospective risk-adjusted target level of Medicare spending per beneficiary in the ACO. And then the actual amount is based on retrospective DRG and RBS payments to hospitals and physicians. So this is where, I'm sure you've heard this a lot, where coding becomes very important because based on what you say the patient has, they're going to reimburse based on that. So if you don't, put in the heart failure, don't put in the pneumonia, the hospital and eventually the accountable care organization, which will include the providers, will get reimbursed less or be expected to spend less on that patient. And so they will, and then essentially what it results in is a reward or penalty up to a cap. And then there's also some certain quality metrics which need to be met as well, including low readmissions and high cancer screenings. And these organizations can then choose which kind of model they want. So they can have a two-sided model with rewards and penalties, or a one-sided model where they just get rewards and no penalties, but the rewards are smaller. So there's also some provisions in there for healthcare prevention. So for private insurance, there's no co-payments for A and B rated services for preventative. This is under the U.S. Preventative Task Force. Medicare, there's no cost for an annual physical to the patient, and they get what's called a personalized prevention plan annually. Medicaid patients don't have to pay anything for smoking cessation drugs for pregnant women. Primary care physicians who work in a shortage area will get a 10% Medicare bonus over 5 years. Medicaid, they'll get fees increased to Medicare rates for 2013 and 2014. And this is for all primary care physicians. And then there'll also be grants for training programs and financial assistance to trainees who work in shortage areas. And then for federally qualified health centers, for example, I think ours counts as one because it's a teaching health center with a primary care residency. The federal funding is going to increase from $2 billion a year to about $5 billion in 2015, so this year. So what are some other public health measures that the ACA is trying to do? So they're increasing the prevention and public health fund from about $500 million in 2010 to $2 billion in 2015 and onward. And eventually it'll go down supposedly as health outcomes improve. There'll be employment-based wellness programs, so there's a financial reward up to 30% of premiums to lose weight or stop smoking. The chain restaurants, anything that has more than 20 stores, must provide calorie information on menus. So here's a Sonic Oreo shake, which is about 1,800 calories, 93 milligrams of fat, this much sodium, and that much sugar, which is incredible. And then a 10% tax on people with tanning beds. So what has happened since 2010 in terms of things that have stayed and things that have gone? So the first thing that was examined by the Supreme Court and ruled on was the individual mandate clause. So it barely held, and it was under the taxing clause that it held. And these are some of the quotes that came out from the Roberts Code. So, but essentially the individual mandate did hold up. The Medicaid expansion, however, which essentially was under this section of the ACA, where it said that states not complying with the ACA's Medicaid expansion will lose all of its federal Medicaid funds. So if they didn't set up an exchange, if they didn't participate in the Medicaid expansion, they were going to lose this funding. And essentially the Supreme Court struck that down, saying that this was unconstitutionally coercive under the spending clause. And the quote was, "What Congress is not free to do is penalize states that choose not to participate in that new program by taking away their existing Medicaid funding." So what that has then done is led to this, which is, this is a map showing the states that have expanded Medicaid under the ACA. So here all of those are in blue. And then you see 21 states not moving forward and 2 states where it was up for debate. And these are the states that ended up setting up what the state-based marketplace. These ones in the dark, the light blue is those that have federally facilitated marketplace, and then these kind of medium blue ones have what's called partnership marketplaces. So they work with the federal government, and they have a joint kind of setup. And what you see here is the trend in uninsurance for non-elderly adults from the first quarter of 2013 to quarter 2 in 2014. And here it is, it's starting. So in those states that did take the Medicaid expansion, they sort of started at a lower number, so at about 15%, and they're down to about 10% now, versus those states that did not take the expansion were higher, accounted for more percentage of the uninsured, and it only went down about, I'd say, 2% with the federally facilitated marketplaces. So then the most recent ruling was this year, and that was King versus Burwell, and that was the question of whether those federal marketplaces could exist at all. It would have eliminated the insurance for people who obtained insurance via the federal exchanges, which is about 6 million people, and there was then a 6-3 ruling that the exchanges through the federal marketplace exchange were lawful. And that was the quote from Chief Justice Roberts. So it was a ton of information in a very short amount of time. I tried to cover it as succinctly and, like I said, as objective as possible without not putting in my own opinions or biases about what's good and what's bad about it. But I'm happy to talk to anybody about it further, answer any questions. I'm sure. Anyway, so hope that was helpful. It's an important issue that, things are going to change a lot more going forward, and it's important to understand where we're coming from and why this came in about.